everyone. It's a pleasure to be here again for a fireside chat with our guest, Professor Marlies Schijven. Marlies has been at the forefront of healthcare education and technology for a number of years and holds the position of Professor of Surgery at the Amsterdam University Medical Centers, as well as being an academic. She's also part of the government. She is currently the Chief Medical Information Officer for the Dutch government. So we'll explore all of these going forward. So Marlies, thanks for joining us.
Thanks for having me.
I guess the first question really is, how is the COVID pandemic affecting the Netherlands at the moment?
Big question, right? Yeah, how is it not? You know, the whole society is disturbed, as well as healthcare is, and you know, we're trying to cope with it as best as we can, both in terms of caring for our patients, as well as caring for our students who are striving to become a medical professional in restricted times. So yeah, it impacts every level, but it also generates another kind of dynamic, which makes a lot of creativity flow and flourish.
And we've seen that with, you know, the pandemic has accelerated change, of course, and allowed us to innovate much more rapidly with less regulation and more, I guess, interest in innovating quite fast, it seems. The Netherlands has always been, in my opinion, at the forefront of innovation in healthcare. To many conferences where people have spoken about the kind of the creativity and the desperation to move further forward. Can you give examples about what you're doing as CMIO, for example, in that role?
Yeah, I guess we have to, because we're so small. If we risk getting trampled and unnoticed if we aren't creative and reach out. In terms of collaborations, in terms of language, in terms of, you know, we have to, and it has become part of nature. Of course, the Dutch have been very explorative since you know, since ancient times. So that makes it part of our genome, I would also almost say. And coming back to your question about CMIO, I think, you know, I think our government became more courageous in these times, more courageous in terms of openness, in collaborating also with people who criticize them a lot. There's much to do and much to say about things like the Corona Melder app, you know, and it's not so much about being for an app or being against an app, but to engage into the public debate and try to make you know, make ends meet and incorporate everyone's opinion if it makes sense in order to get to the next level. And for my work, I've worked on the, in Dutch it's called ziekenhuisbed checker, which is unpronounceable. So it's called hospital bed checker, in which every professional has access to a website where you can see for yourself how many beds there are in the hospitals, if there are COVID or non-COVID labeled, if there's opportunity to welcome patients in the hospital or not, you know, to see the pain points. And that takes courage of hospitals to open up for that. In the other end, it helps in better registration because it's all out in the open now. And it helps in the public debate, which patients have to go where, you know. So yeah, I think these times help us to become more mild, to better understand each other's needs, and to better understand how technology can help us.
Yeah, so I think that's amazing. The fact that you've led a transparent process of showing real-time data on hospitals and flows, etc. How do the patients cope with that? Because obviously sometimes they don't see the hospital workings, functions, capacity, and they make, I guess, influences around that. Has that helped your debate with the patients? Are they much happier now because you're seeing them?
I don't know if they're much happier. I think it helps them understand a bit better. Although, you know, there's only so much stretch in people's mind. You know, if you have to have help, and if you cannot have help, you know, in the first part of the pandemic, people applauded for healthcare workers. And now we see, you know, in the second wave of the pandemic, it's becoming much harder for people to accept that they are not being helped again, or how to explain to a person who has a disease, if it's cancer or not, that they have to wait. And while the ORs are not turning because we don't have the staff to equip the ORs, and even if we have the staff, we don't have the beds at the ICU. So it's showing what's actually happening in the country. At least it gives them the idea that we're not hiding stuff, which helps in building trust.
No, and trust is so key at the moment, of course, during the pandemic. That leads me to the next question, really, around data. Clearly, you have some data there. What's the kind of attitude to the Dutch healthcare system on data? Everyone struggles with interoperability, for example, access, patient empowerment. What are your thoughts, Marlies, as the kind of CMIO, at where you are now, where you'd like to be the next 5 or 10 years?
Yeah, well, our government has not chosen for one hospital system, so they gave it up to the market, which has led to a competition, which may be a good thing, but has ended up with problems in interoperability, of course. And these times have led to more regulation on that. Because the government previously did stress on open standards, on sharing, on reuse of data, but as long as the bigger players were not forced to do so, they had a competition interest not to do so. And it's one thing to stress that data needs to be shared, but if you're not enforcing it, and if the hospital only has so many means, it's no guarantee they will do it. So that debate, the brokerage servers between the hospitals, that's a heavily debate going on at the moment. And what I think, my role, I see. Let me give an example. Last week or 2 weeks ago, I did a Zoom session with the government employees on the patient system, because they have never seen a patient system in action.
Okay.
So I created a fake patient in our actually hospital system with a fake letter of a general practitioner sending the patient to me, and I took them by the hand, so to say, via Zoom, what I need to do in order to get things done. And it was they went berserk. Because then they saw, if I have to register simple as an allergy, how many steps are required of being able to capture the natural interpretation of typing language. So you have to search for the right tag instead of the system helping you. So, I see my role as a enabler, as a, to give people insight on each other's challenges. And I think it's very courageous of our government to embrace a critical person like me into their system.
Well, you're the right person to challenge and ask the right questions. And I'm glad they shared your frustrations on turning a computer on and going through the electronic health record and navigating through the different that we all face, which is quite important. So I guess the next question really now is, okay, what are the key challenges you set yourself, or the government set themselves, where you're part of that kind of long-term problem-solving solution? So say next 5 to 10 years, where do you think you'd like to be in terms of and what the key challenges are for the Dutch healthcare system?
That's a difficult question. I don't think it's wise to keep people too long in such a position at one place. It's honorable, and it's it brings you places, but I think for the system it's good to have a changing viewpoint on these matters, because that helps bringing things forward. You shouldn't keep a person too long in one place. So I hope I can give them insight and make myself not needed anymore, because the insight has landed. And how long that takes, I really don't know. I think we just started. Of course, you need some time to do the job. So in my perspective, anything between now and 5 years or something is a good time window for that. And I think it's important for people to understand we're not each other's competitors in getting better healthcare to patients. We only have different viewpoint angles, but in the end, we all have the same interests. And it needs to shave a little bit against each other to get the sparks and to light the engine and to fire up things. But I think the mutual understanding and respect, and to be able to step into each other's world, virtually or not, is important. And that's why I admire your work a lot, Shafi, bringing people together and using technology that, in my perspective, is not cold but very warm, in showcasing, in inspiring, and also in helping build relationships between people across boundaries.
Talking about building relationships, one of the key things we found in the pandemic in the UK is that there's been much more close relationships between industry and the public partners. In fact, we have companies coming in who are much more able to come in and help deliver some healthcare services with the NHS. Are you finding the same in the Netherlands? Is there closer collaboration? What's the relationship with industry at the moment?
It varies a lot. There's a difference between. I think there's a huge array of in that scale. There are startups. There are people who just getting by with some seeding capital, and there are the big industry firms. In my country, you have to disclose everything, which makes it, in terms of transparency, we even have a transparency register in which you have to, to settle every relationship you have. And what I sometimes find a bit painful, but that's how life is, I guess, is that some smaller firms might have very good ideas and very bright, who are unable to land in our healthcare system because they're so small. And then again, you see the bigger pharma tech who is eager to almost, spy on every initiative in order to get the best out of it for themselves. And, I know that's how the world works. And, the bigger firms are eager to look in our OR also, where we have settings who are to explore things. And you see them scribbling on their notepads and taking things back to their firm, while the people I work with are often small industries who have a bright idea. And that to me is a delicate balance in bringing small technology forward and having to lean or wanting to lean on the bigger firms in order to get things done. I guess that, I guess you understand what I mean with that.
Of course. So I think the other thing around this is that, of course, you've been a great protagonist for mHealth for many, many years. And I think that's how, when I first met you a while ago, when you experimented with Google Glass and technologies and that kind of thing. We're now moving to eHealth. And what the COVID has shown us is that patients now can be monitored more at home, whether it's asthma, diabetes, or other chronic diseases. Are you seeing the same transitioning of patients from secondary care to primary care or remote care, as it were, in the Netherlands?
Yeah, we do. There's a lot of interest for that also. And I think in this case, it's not so much the technology that limits. It's the way that our infrastructure is not built around it. I mean, if patients are wearing, for instance, let's say bandages or stickers monitoring their heart rate or whatever, and they feel protected because they're wearing technology that's able to grasp their vital signs and is able to send their signs to a place. We have a lot of questions not solved around that a place. What happens with the data? From whose data is it? Is it on safe servers? What happens if a patient has, for instance, a heart attack at 12 at night? Is someone going to read out that data? Is someone getting alarmed automatically? Are there AI algorithms that are safe? Are they ethical? Are they able to bring back that information to the patient health record? And who is liable if a patient gets a heart attack at 12 at night? Those questions, much more than the technology, is what we need to solve.
I think you're right. I think we're all struggling with the same kind of problems. And I think one of the things the pandemic has shown us that we are creating global solutions. One of the things to think about going forward is how do you learn from other countries, other experiences that you can take back and hopefully share commonality going forward, which I think we all share the same frustrations, of course. So I guess next really question is around your thoughts around technology as a whole. I know you've done some amazing work, by the way, one of the real leaders in technology and healthcare around the world, particularly as a surgeon, of course, with a busy full-time career. So technology is obviously transforming our lives. Do you think technology has the ability to make us more human, Marlies?
Yeah, I think if well fitted, it does. But those are three words that are very important. You know, I think technology can augment us in a good way, but also in a bad way. A mobile phone can be a great help and can also be a great distraction. So it's about fitting things in a process that helps bring the process further. And sometimes that's technology, sometimes that's something else. I think technology is an asset as well as you know, a human hand is, or a good nutrition is, or it's part of a, you know, of a toolbox, but you need the right hammer to nail the nail. And you know, just having a very shiny gleamy toolbox makes you parading around like a kid, but in a sense it doesn't help you build a house. You need skills to work with it, and you need to choose the right stuff. And I think on that level we need to we can still offer people a lot of help, and people need a lot of help to be able to work with it.
I think you're right.
No, I give an example. I'm sorry for that, Shafi, but you know, if I'm what boggles my mind, for instance, that in our hospital I have to do several e-learnings or trainings on important things like you know, if household violence I have to do training about, and I have to do a fire extinguisher training, and I have to, you know, all kinds of trainings. I never ever had a training how to work with the endosuite. Or, you know, I never ever had a training about, you know, equipment that I use in the OR. I even didn't have a training how to work with the hospital bed that I'm still unable to lift the head and you know, the things you work with in daily life, and which we have to be able to master. We you know, we have this strange perception that it comes naturally to us to work with those things, and if shit happens, and shit happens, then we all look at each other how to fix this and press every button, and you know, and in the end it either works or we get something new inside the room. That's how we work.
And that's because we should be, as you say, be thinking about how to bring the workforce of yesterday into the future. We've seen some change in the last 9 months. We changed the language, of course, of workplace in terms of technology. And I agree, technology is an enabler. It provides solution. It's not the only answer. It's about kind of change management of society. So if we're going to create a more digital workforce, how do you think we're going to be? What do you think we should be doing in terms of the students, the trainees, the healthcare workers? How do you bring digital literacy much more to the masses in healthcare?
I think we need to take ourselves seriously and to acknowledge that we don't know a lot about what we just talked about. And you know, all of us are eager to learn, but none of us are eager to being taught or to have to do exams. You know, we can grow as a society in helping each other understand that we deserve this type of knowledge, and we need to, you know, to be able to get this type of knowledge and to invest in how to work with technology and learn about that, and to, you know, to bring it into the curricula, and but also to enforce it, because, you know, as we have seen with simulators, there's beautiful stuff out there. People don't use it unless you make them to.
Yeah.
And if they work with it, they say, yeah, it's brilliant and I have fun and I'm getting better. And, you know, once they experience it, they say, yes, I am very good. I didn't want to miss it. I'm a bit, but, you know, they talk, we assumed when people would have had that experience, it would spread naturally and people would talk about it and their peers would engage in. That's just not the case.
Yeah.
And we also need to acknowledge that.
I think you're right. I think allowing just diffusion to happen isn't good for a government or a healthcare system. It has to be proactive. It has to be embellished into kind of curriculum and models of care. So I'm totally agreeing with you. And I think we've got a lot to do globally on how we change the language of healthcare so that it becomes more relevant for today's society. I'd like to ask a kind of a question around your research, actually. I've always been fascinated by the wonderful work you're doing with the kind of black box, the OR black box, if you like. Can you share what that is to our audience and what it might mean in the future for kind of surgical practice?
Yeah, it's not my invention, not by far. It's the invention, or it's the work of Theodore Grangerov that we implanted in our hospital. But implanting technology is, you know, research in itself. And what we did, we have a close collaboration, and we decided to use the black box, which is actually, you know, an overview monitoring system of different data sources. And you have to define your use case. Your use case can be looking for error, can be optimizing workflow, can be, you know, thinking about what to use and what not to use, equipment failure. But we chose to use it for very primal questions, namely, are our hospital employees at the OR satisfied with using an OR black box in terms of looking at the output it generates? Can we use the output for team debriefing? Because we don't do team debriefing with the people at the OR. And the best way to build stronger teams and to reduce error is to understand each other better. And for that, you need a template, because if you do a team debriefing and have everybody, you know, recollect from their experience and mind what happened, you get 10 different versions. And it's very hard to get to a common denominator if you don't have an objective underlier of the discussion. So we used the OR black box to bring back every OR to 10 minutes template, in which there was basically a storyline, and which you could go back to situations in which there was either confusion of language, or confusion in understanding, or you know, a technical error, which does not necessarily mean there has been an eventful situation, but there has been a situation to talk about. And that we did. And you know, there were I believe there were, I have to do this from memory, but there were over 100 persons exposed to the system or working with the system. We tried to get very critical people who didn't want to work with it inside this environment, and 89% was very satisfied with the use of the outcome report for the purpose of team debriefing, because it helped them to express their concerns. It gave a voice to people who normally don't speak up, because the team debriefings were led by a psychiatrist, in order to keep the surgeon and the anesthesiologist at bay, and also have the intern have their say. And that, you know, I changed my surgical routine after the second time I was in that black box environment, based on a remark of a OR nurse who would not have spoken up to me in a good way if we didn't do the team debriefing. So that for me was such an eye-opener that, you know, I became a very big advocate for the system. Although I must say our hospital has been very courageous. It was the first in Europe to do this. I had to go to, you know, to the minister to be able to film our hospital employees. I had to build in, again, that's the set of rules around technology that I had to ensure, because you cannot videotape hospital staff. So we had to go for privacy by design, to blur from from capture of imaging, not post-processing, all those conditions, which has been a journey in itself. And I learned so much from it. And, we have one system now. We were looking towards install in all our ORs, but unfortunately, COVID has thrown a lot of dust into this times. Our hospital finances have gone down. So we are looking for creative ways to enable some of our ORs with it. And that's how it is now.
Incredible. Yeah. So good luck with that after the pandemic. Hopefully you can disseminate some of the information to other parts of the world. So we talked about data, we talked about the OR black box and how you've used that transition some of your ideas and practices. That lends itself to a natural conversation around AI, of course. In the UK, we have been now quite proactive with NHSX and the AI labs being set up and a lot of funding being given to companies who are going to be using AI in healthcare here. What's the situation of AI in the Netherlands? Are there user cases? Is it being embraced? And perhaps share some experiences of what you've seen so far.
Yeah, well, AI is like, 10 years ago, everyone was on the VR, and then it became on the AR, and now it's on the big data and the AI, with a few people understanding it, including myself. It's a whole world out there. It's the neural networks, and I believe, for pattern recognition, AI will be the next thing. That being said, I also think that it's very, very, very important to ensure that we need to keep on thinking using AI. AI will do a lot of hard work for us, but we need to keep on thinking what it gives us back. Because otherwise we rely on stuff we haven't control over, because then it controls us. And an AI algorithm isn't smart in itself. You have to build it. There will be errors and bias and flaws inside it.
Sure.
You need to have a regulation system, evaluating AI, being able to deconstruct and construct. That there's whole science around it. And if it's on purely pattern recognition, like for instance, radiology imaging, or where interpretation might be less difficult, so to say. I hope radiologists won't murder me now. And then making decisions built on more fluid information. Yeah, I think in those areas it will help us a lot. But another example is, for instance, we have in the Netherlands an app that recognizes health skin problems, and in many cases it's able to to see or differentiate a good mole from a bad mole, a melanoma from a birthmark. But if there are so many conditions alongside, if the light of the monitoring is not well, if someone doesn't take the picture well, if it's blurry, if it's whatever, if it's misdiagnosed, you may even have a bigger problem than a doctor who misdiagnoses in their own setting. What do we agree upon? That's the basic question. What do we allow? And technology is able to do a lot, but how do we set our rules working with it?
Sure.
And that's a big question, and that can only it's like discovering a new language or you need to understand the language, and you need to and that can only be done by talking a lot, actually. So those rules and guidelines will be formed while it's being built. And the risk is that you are unable to understand faults because you don't have the words for it yet.
Yeah, I think you're right. So I think one of the key things we've discussed today is about technology being an enabler. It's going to be a great solution for a lot of things. It's not on its own. We need rules, regulations around it. We need government interventions. We need a vision and strategy. So, and it's great to have you as a CMO of a country where you're thinking about change and how you administer that sensibly in a way and in a fashion that also covers the ethics and the confidentiality, which you've worked for a while and is now our black box. So I think we're to the end of our session. I'd like to thank you for joining us, Marlies, from your busy schedule, and I'm sure that the audience will find your insights particularly helpful as they think about this whole area of digital transformation. So thank you very much.
Thank you very much for having me, and looking forward to our next collaborations.
Me too. Thanks so much.
Thank you. Bye-bye.